Of course, my last not least presenter is Dr. Murtadha Al Khabori. He's a senior consultant hematologist from Sultan Qaboos University and associate professor. He received his hematology and bone marrow transplant training in Princess Margaret Hospital in Toronto in Canada. And of course, research training in McMaster University in Canada.
Thank you, Dr. Adil, and thank you, Dr. Hamid, for the introduction. And I would like to thank Dr. Ali, Dr. Saleh for the, and the other organizers for the invitation. My talk today is titled Regional Cancer Research Priorities During Pandemics. I'm a hematologist, although it is still within the oncology, although this is more fluid, the liquid malignancies. So my objectives is in the next 20 minutes or so to briefly review publications related to cancer and COVID. Then review the status of clinical trials prior to COVID in the GCC region. Discuss the immediate impact of COVID-19 on cancer research. Discuss the long-term impact of COVID-19 on cancer research, and then some of the take-home messages. First, the publications related to cancer and COVID. Now, we know, I mean, it's not a surprise that COVID impacted many publication fields, including oncology. When you go to PubMed and you do a free text search with the word cancer and you retrieve it, and then you also do this for COVID-19 and you retrieve it, you see this pattern. So starting from 2010, which was our limit, to 2020, you see a nice increasing trend in the number of publications, up to almost 225 documents indexed in PubMed in 2019. Unfortunately, in 2020, you start seeing the impact of COVID-19. I mean, there is almost 25,000 documents missing compared to 2019. This is likely the impact of COVID. Actually, it's even more than 25 if that improving trend or increasing trend continued to be the same. So almost half, or almost 200, maybe 30, 40,000 if you do some forecasting. Now, if you look at the COVID-19, you see interesting trend. The first time COVID-19 get reported is in 2012 as per PubMed indexed. And then it maybe got some interest in 2013 with 7 publications, then it died. In 2018, it came back again with maybe 6. And in 2019, 250 publication indexed in PubMed. And then in 2020, no surprise, 75,000. This is almost 1/3 of the publication of cancer. Whatever you built in years and years of cancer literature, now COVID-19 in less than a year got almost to 1/3 of the cancer publication. So it is clearly showing a major impact. And if you forecast 2021, I can tell you that that number of COVID publications would grow higher, and number of oncology cancer publication, if that worrisome trend continues, it will be probably less than 20,000. Now, so we see a major impact on publication. The next question is, what is the status of clinical trials prior to COVID-19 in our region, in the GCC region? Now, this is a work of one of my students, and it is already submitted. This is not specifically addressing cancer, it's addressing clinical trials in the region. So what he did in his retrospective bibliometric analysis research, he went to clinicaltrial.gov and pulled all documents from 2000, from 1st of January 2000 till October 2019, when he did his search. He pulled all clinical trial documents with a country of the GCC, so Oman, Saudi Arabia, UAE, Qatar, Bahrain, and Kuwait. He excluded the duplicate studies and those with the missing data. And these are his findings. So out of the global clinical trials, we contributed in the last maybe 20 years, almost 682 clinical trials. So this is, if you compare this to the global production of clinical trials, the percentage is 0.3%, 0.278 if you want to be really accurate. This is very discouraging number. I mean, looking at our population, we expect to contribute more. Now, if you look at the distribution, not a surprise, the Kingdom of Saudi Arabia would be the major contributing to the clinical trial, with almost 485 out of 682. But if you compare to the countries like Europe, Turkey, the region there, as a global GCC, so almost 30-40 million people, we expect again to contribute much more than this. The second question in this study is, maybe this is not fair to some of the other smaller countries, and let's try to adjust it per population. So he divided it, or he adjusted it to the population of the country. Here, the Kingdom of Saudi still remains maybe high, but it's still the second. Qatar came first. Now, unfortunately, Oman scored the least when you adjust it for the population. So in Oman, we scored like 5.6 compared to, let's say, Bahrain is like 11.9. So I don't know whether this is a fair comparison when you adjust it to the population, but it's somewhere of normalizing the data to the population. If you look at the trend, now at least some good light out of it. If you look at the trend, you see increasing number of publications as we go along. So from 2000, with almost like maybe like less than 10 documents of clinical trial, to increasing to almost getting to 90 in 2018. The decrement in 2019 is likely related to the time of search. So the good thing about it is that we've been increasing in terms of doing more clinical trials. And again, if you look at the driver of that increase, the Kingdom of Saudi comes as a major driver for that increasing trend in the number of clinical trials per year. Now, if you look at the subject covered, global over GCC region, oncology is the highest, 106 out of the 600 and whatever documents for clinical trial. So that reflects the importance of cancer research. The second that comes here is the endocrinology, and then cardiovascular, which is not a surprise. And I mean, to my surprise, hematology only scored like the sixth or the fifth, which is not what I expected. Actually, if you look only into Oman, hematology outscores oncology, outscores solid tumor with the leading number of clinical trials in Oman. But globally over GCC, oncology is still the highest. If you look at the phase of clinical trials, again, not a surprise. Most of what we do is phase 2 and phase 3, as reflected by Dr. Abdul Ali in the previous presentation. And as we expected, phase 1 would be very small. Over 20 years, we had like 21 phase 1 studies. Now, when you look at COVID, during COVID, as I would present and was presented, that COVID led to holding of many clinical trials, shutdown of many clinical trials. And then if you look at try to analyze which clinical trials were shut down, it is the clinical trial that we don't know or difficult to expect the fate of. So if it is a phase 3, almost done, you could just analyze the data, and if there's a promising pattern, you go on and continue, and you don't hold on it. But what got really affected is the phase 1, because proportionally, the number of successful phase 1 studies would be less than what you would expect for a phase 3. So phase 1 probably got affected most. And if you look at in our region, because we contribute the minimum to phase 1 studies, this is where the least impact is. Now we finished kind of addressing the status of the clinical trials in the GCC region. We go to the next question: is what is the immediate impact of COVID-19 on cancer research? I apologize for some of the redundancy because some of this was presented before. One of the major negative impact of COVID-19 is are the fears and concerns for safety. So patients felt very worried about coming to health facilities, to hospitals, to health centers. And also staff may be worried of coming to the hospitals and even seeing patients. Now this, with the lockdown, with the difficulty in getting your reagents, shipping the drug, getting the IMPs from the sponsor, this led to clinical trials to be held in many areas in the world, including in our center. Some of the studies, again, as we said before, got shut down. There was also concerns about resources. So, you know, when COVID-19 came, it was, no, please don't use the PPEs. Let's just direct it to the COVID-19. That also translated not only in PPEs, also in other areas in staff. Some of the research staff in some centers went and helped with COVID. Some of the surgeons, Dr. Adi will attest that some of the surgeons went and helped with the COVID units. So this is kind of the negative impact of the COVID-19. However, there was some immediate positive impact. Now, there was a clear attention that that research is important. COVID-19 is a new disease. So everyone looked at research and researcher to try to solve what is this disease? How do we diagnose it? How do we treat it? How do we produce vaccines for it? So it really brought the public attention significantly to the importance of research. I was just 2 weeks ago trying to enroll a patient for a phase 3 study. And it took me a second just to try to say this is a phase 3 study. And I'm just trying to explain what a phase 3 study. And the patient said, well, I know what a phase 3 study. This is where the vaccines now, the COVID vaccines are. So it took a lot of our burden to explain to the patients. And then in terms of patient acceptance, before, patients were saying, we don't want to, especially in our areas, we don't want to be the guinea pig for your clinical trials. But now, no, I want to participate, not just because of, I'm sure there is an element of that we want to contribute to science, but we also want to get the benefit of being enrolled in clinical trials. The second positive impact is it highlighted some of the groups of patients, including cancer and other immunosuppressed patients, like post-transplant and cancer. So that may give some of those patients a priority. So when you look at the regions, most of the routine work stopped or was on hold, except cancer healthcare. So I know it, despite this, as Dr. Mark previously presented, the cancer research, the cancer care also got affected, but at least it got affected less than the other field. It also, the other positive impact is it exposed the limitations of uncontrolled studies. This is close to the heart of health research methodologies. We know we believe in randomized clinical trials, and COVID highlighted some of the deficiencies of uncontrolled study. We know that with the trials of convalescent plasma. We know this with the trials of the hydroxyurea, something we really looked for, hydroxyurea, and then something that we deserted and we stopped using after the phase 3 trial. It also, COVID-19 highlighted the slowness of existing processes. You know, things were taking a long time, not just in clinical trials, in review for grants, in approval of research and ethics, in our many administrative processes that we have in health centers, in hospitals, in research centers. that highlighted the slowness. We were asked to do things much more efficient, and we were able to, with almost provision of the same standard of care. This is like, as an example, as Dr. Abdul Mu'ti mentioned in his previous study, we were able to, I mean, in terms of scientific community, to produce vaccines 5 times faster than what we used to. So I hope that positive impact would stay and would continue after COVID. Part of it, also FDA got better. So in March 2020, they released their guidelines of what to do with it. They tried to reassure sponsors that any deviations that we do as part of COVID management would be acceptable. So it would not lead to like, no, we will not approve your drug. We will we will ask you to shut down your study. As far as it approaches a common sense and it refers to the problems raised by COVID-19. Actually, that March 2020 led to a number of changes that was adopted by sponsors and other researchers. So sponsor accepted virtual visit data on patient status, use of local labs, shipment of the drug to patients' home. Those are major changes that are done in how you run clinical trials, and it improved the efficiency and probably the cost of running the clinical trials. So also sponsors now agreed to reimburse for telemedicine. So if you see a patient as part of a clinical trial, you will get paid if you see even through the telemedicine platform. It also led to rapid reviews of an approval of clinical trials, as we've already listened to. The last thing that I want to, the last thing I want to highlight is the indirect impact of COVID-19 on cancer research. So not directly, but COVID really had a major impact on economy. Public funding went to COVID-19, private donations went to COVID-19. So during this time, and likely maybe 2 or 3 years after COVID, the research funding for cancer and other fields would likely suffer. It also has a major indirect impact of students doing their postgraduate studies, master and PhD, as students who stopped getting samples, who did not get their reagents, who could not do their courses, who could not come to the lab, and their PhD is like on hold. We could not use grant money for some of the studies just because of this COVID-19. The other indirect impact is on the validity of results of the current study. Some of the ongoing studies, including clinical trials, had to be compromised. Less visits, less patients' information, less results from lab tests. And that would have probably a major impact on the validity of the results. When it comes to the interpretation as a reader or even as journals, like when you come and review the publication of studies that are done during COVID time with major missing data, major loss of data, major loss of follow-up, we would be challenged of how to deal with this. And it likely would get affected. Like people would look at this with a grain of salt. Now, the other indirect impact of COVID-19 on cancer is the availability of new therapies. I mean, for relapsed refractory patients, we were looking into clinical trials to enroll those patients in and potentially benefiting those patients. Unfortunately, that got affected because of the closure and the delay of clinical trials. This is likely to stay for some time. And here, the responsibility of sponsors, pharma, with using or expanding their expanded access program. This is one of the ways that our patients, especially relapsed refractory, could get access to new therapies that are not registered in the country, and they could be we were provided on clinical trials, but now you only have the expanded access programs to do this. Now, what is the long-term impact of COVID-19 on cancer research? It likely would have a major impact. So we would be doing more of telemedicine that would improve convenience for patients. And we would also reduce disparities. Something that Dr. Marcia spoke about is the disparities between communities, between countries, between high and low income. Here, where you can reach patients through telemedicine and you can enroll them in your clinical trials, you will be able to reduce that disparities. So it's likely to enroll patients of a wider spectrum. And then also part of the quality assurance for clinical trials, with the frequent visits of your monitor, the repeated annoyance of your monitor on the source documents. Now this is likely to be done through remotely. This is likely to be more frequent, and hopefully we look at less annoyance from your monitor on the source documents.
Murtadha, you have 1 minute.
Okay. So the last thing that the last slide is the design and approval. So we likely would see a change in the design of clinical trials. It would have more respect for patient preferences and values, i.e. that means you would simplify your protocol. It would be cheaper. You would do less tests and less visits. We know that we could do it in COVID-19 era, so we would likely be able to do it afterwards with sustaining the validity of the clinical trials, and also the speed and review of approvals of clinical trials. So take-home messages. The number of cancer-related publications decreased after COVID-19. The contribution of the GCC to the clinical trials is limited and likely to suffer from COVID-19, including cancer clinical trials. Fears and limiting movements, lockdowns, led to shutdown of many clinical trials. The pandemic highlighted the importance of research in solving problems. FDA approved using a common sense approach. Clinical trials are likely to be different post-COVID-19, and funding for cancer research is likely to suffer post-COVID-19. These are my resources. And again, I would like to thank the organizers for the invitation and thank the audience for their patience and listening. Thank you, Dr. Ali.